Good afternoon, everyone. Welcome to the part 2 of session 3 of the 2020 National Health Research Forum for Action, or NHRFA 18. Today's topic is on service delivery amidst COVID-19, ensuring continuity of health service delivery amidst COVID-19, with a focus on special populations, migrants and overseas Filipinos, elderly population, and children. The Department of Health, DOH, Department of Science and Technology, Philippine Council for Health Research and Development, DOST PCHRD, and the Ateneo de Manila University Institute of Philippine Culture, ADMO-IPC, are providing this webinar as a public service, but it is neither a legal interpretation nor a statement of DOH, DOST PCHRD, or ADMO-IPC policy. Reference to any specific product or entity does not constitute an endorsement or recommendation by the DOH, DOST PCHRD, or ADMO-IPC. The views expressed by speakers, facilitators, and viewers are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Views and opinions expressed by DOH, DOST PCHRD, or ADMO-IPC employees are those of the employees and do not necessarily reflect the view of the DOH, DOST PCHRD, and ADMO-IPC or any of its officials. Just as a reminder to all our viewers, in cases of disconnection from our webinar, please refresh your page or click the link that is provided to you to access the webinar. We will allow you to just enter the room and join the webinar session again. Thank you. Our facilitator for today is Ms. Michelle Daabay. Ms. Michelle, good afternoon.
Good afternoon. The Philippine Standard Time is 1:02 p.m. Welcome to the 18th National Health Research Forum for Action. This year's forum aims to showcase local evidence, breakthrough findings, and developments in health policy and systems research, geared towards the realization of the universal healthcare in the context of the current COVID-19 situation in the Philippines. We're now in the session 3 of the forum, deep diving into the title, ensuring continuity of health service delivery amidst COVID-19. Yesterday, we had the part 1 of the session 3. Everybody was engaged, leading to fruitful exchange of ideas. The discussions revolve around the crucial role of having enough number of competent and committed health workforce and functional facilities and ensuring health service delivery as mandated by the Universal Health Care Act. Today, we will continue on the part 2 of the session, zooming in to the special populations, the overseas Filipinos, the elderly, and the children. Once again, I welcome you all to the 18th National Health Research Forum for Action. Thank you for joining us today. To formally start the program, we will have a short prayer.
Let us put ourselves in the holy presence of God. Father in heaven, always merciful and giver of life, we humbly ask that you bless each one of us, from the speakers, program committees, guests, and participants. Guide us to make better decisions as we incorporate what we will learn throughout this activity. Thank you for the infinite blessings and countless opportunities. Lord, today as we start our activity, may we always be grateful to learn new things. Shed the light of your wisdom and bless each one, especially our speakers, as they will share their knowledge to us. Through your mercy and grace, may peace and utmost understanding shine and dwell unto us. Almighty God, Accompany each one and help us concentrate for us to gain more knowledge as we listen attentively. This we ask in your name. Amen.
I know everyone is excited to continue the discussion on health service delivery amidst public health emergency. But let me just welcome the participants who just checked into the platform. Good afternoon. At this juncture, we will proceed to the research presentations. We will be joined today by STEAM researchers. After each presenter will be given exactly 20 minutes to discuss their studies. After each presentation, 10 minutes will be given to our panel of reactors to raise a few points, and another 10 minutes will be allotted for the question and answer portion from the questions that we will collated from the chat box. But before we proceed to the first presentation, let me remind you of our webinar rules. If you encounter connection problems during the webinar, please click the reconnect button found at the top of your screen. Second, please use the chat box on the right side of your screen for questions and comments related to the webinar at any time. They will be read after the presentation. Third, please state your name and affiliation with your questions and comments. The last one, the most important one, we value respect and courtesy the most during our webinar sessions. I am Michelle Nita Abay, and I will be today's facilitator. For the first study, we will be joined by Dr. Joel Benaventura. Dr. Benaventura is currently a health program officer in the Bureau of Health Cooperation. And today, he will be presenting his study entitled Health Services for Migrants Filipinos During COVID-19. This is really timely and relevant, as we all know that the current COVID-19 significantly affected health, economy, and mobility worldwide. Don't you know that a tenth of the Philippine population is either working or living overseas? So it is very important, imperative to look into how COVID-19 seriously impacted our migrants and overseas Filipinos. The presentation will highlight the various policies and interim guidelines issued by the Philippine government in order to ensure the continuity of health service delivery for migrants and other overseas Filipinos during COVID-19. Welcome to the forum, Dr. Joel Benaventura.
Thank you, Michelle. Can you all hear me well?
Loud and clear, sir.
Yeah, I think that's always the first question we ask in webinars. Can you all hear me? All right. So thank you very much. So thank you for the introduction. It's my privilege to be here. Although Michelle has mentioned the esteemed researcher, I would like to have a bit of disclaimer there that I'm more of a policy person. I'm the Chief Health Program Officer at the Migrant Health Unit at the Bureau of International Health Cooperation. More of a policy maker than a researcher. We've come up with basically this somehow study on a policy research on the health services for migrants and overseas Filipinos during COVID-19. So I would like to share what we have done in ensuring the continuity of health services for our migrants and overseas Filipinos in this time of pandemic. So, but before that, I think we have a lot of participants here. I wanted to ask the secretary to run the poll. Just wanted to know from all of you who are participating today, how many of you have a family member or relative who is either working or living overseas? So maybe I can ask the team to launch the poll.
Yes, sir. The poll is now being run, sir.
All right, thank you. So we're seeing the results. So you can answer yes or no. As Ma'am Michelle has said, 10% of the Filipino population, based on the CFO uh, country migration report. So we'll see, are either working or living overseas. So let's see if
Okay, Doc, should we
yeah,
the poll na po?
yeah. Yes. So I think so. Most of you have family members or relatives who know. So 90% of you. So 9 out of 10. So really. So next slide, please. So okay, I think it's okay. Just put on the next slide. So I think that kind of confirms that the Philippines is really a country of migration. This country migration report that was launched in 2013 by the various agencies you see here. Um, estimated that the immigration from Philippines amounted to 10.4 million Filipinos, about roughly 10% of the Philippine population, and they are located in more than 200 countries and territories worldwide. Immigration, those who are here in the Philippines, is less than 20,000. Um, based on this study. And however, it was noted that institutionalized labor migration, or what we are more familiar with, the OFW, or the overseas Filipino workers, it numbered 1.8 million in 2012. I think we breached the 2 million mark sometime in 2015, 2016. And the latest data, according to the Philippine Statistics Office, is that we are sending 2.2 million overseas Filipinos every year in 2019. So next slide. So you see that the Filipino diaspora is concentrated mainly in the Americas. So we have more than our Filipinos who are in the United States tops the list with 3.4 million, according to this Philippine Country Migration Report, and followed by the Middle East. So if you would lump all the Middle East countries in Saudi, Qatar, Kuwait, UAE, this would number uh, more than, I think, 2 million, 3 million. So this is the second largest concentration, and you see the rest of the distribution of the top 10 countries where the Filipinos are. Next slide. Uh, for for the Philippines, it is important to really to address our migrants and overseas Filipinos, because, as I've said, it's about 10% of our population are either working or living overseas. Our Philippine foreign policy, also the third pillar of the Philippine foreign policy, reiterates that the protection of the rights and the promotion of the welfare and interests of all overseas Filipinos is one of the three pillars. So it's really important for us, uh, uh, not just in the health sector, but of course in our foreign policies and migration policies. So addressing the health of migrants and overseas Filipinos is vital in and important in realizing universal health care. Of course, at the moment we are we have the Universal Healthcare Act, and this is really, I think, one of the things that the department has been getting its hands on, is that it's seeking to ensure equitable access to quality healthcare by all Filipinos, whether they're in country or abroad. At the department, we believe that you cannot have universal health care if the 10% of your people who are either working or living overseas are not given access, equitable access to quality healthcare. Next slide. Next slide, please. So in the department, actually, we have a policy the DOH Administrative Order 2016-007, which actually lays the foundation for the policy on the health of migrants and overseas Filipinos. This was signed in 2016, and this landmark policy initiated the establishment of the Migrant Health Unit at the Bureau of International Health Cooperation at the Department of Health. So this is a special program, the Philippine Migrant Health Program, that is addressing all the issues with regard to migration and health. So next slide. So migration and health is really intricately linked, and I think this slide doesn't need any further um, uh, explanation, especially on point number 4, wherein migration it contributes to the spread of infectious diseases, because we know we're all in the middle of the COVID-19 pandemic, and we see that it's inextricably migration and health is very much linked to each other. Next slide. So, in terms of COVID-19 and migration, we all know we live in a mobile and interconnected world. According to the IOM, 1 out of 7 people are on the move. And it's very important to realize that although people are mobile and are moving, they are also carrying with them, organisms, and a health threat anywhere is a health threat everywhere. So just like the COVID-19 pandemic, which started in Wuhan, now it has gone all over the world. And this proves the fact that diseases do not really recognize borders. So the COVID-19 pandemic has significantly affected migrants and overseas Filipinos. So that is why I think we appreciate the efforts of the this 18th National Health Research Forum for Action, recognizing that health services should be ensured during this time of pandemic. Next slide. So this study on basically it's a secondary data analysis study is needed to ensure that the health and welfare of overseas Filipinos is ensured during the pandemic. We think that it's significant because we had to gather evidence and surveillance data regarding uh, the overseas Filipinos who had COVID-19 or were confirmed to have caught the infection. So it's important also to have this study because there's a need to coordinate the health services and continuity of care, especially for those who are returning from abroad. We see this as because the pandemic has affected economies and also certain segments of the economy, especially say the travel industry, the cruise ships. So many of our seafarers actually had to go home and return to the Philippines because of this. So we need to coordinate health services and the continuity of care in case they have health issues. So there's also a need for the policy making bodies for government to issue evidence informed interim guidelines and policies with COVID-19. As we know, the COVID-19 pandemic is unprecedented. We haven't seen before, although we have had previous emerging infectious diseases. It's not at this scale. So that's why we had there is um, significant need to issue evidence-informed interim guidelines and policies based on evidence. So current evidence. Next slide. So basically, what we did for this in terms of the methodology, this is basically a policy research. So we use the secondary data analysis, which involves analyzing data collected from existing data sources. So this study used data from various organizational reports. So these are basically administrative reports, which I will be showing to you in the next few slides, from basically various sources, from the Migrant Health Unit at the Bureau of International Health Cooperation, to reports from the our Epidemiology Bureau, the Quarantine Bureau, the Department of Foreign Affairs, the Overseas Workers Welfare Administration, the POEA, even the some reports from the Coast Guard that were integrated. So it's all of these reports that are generated by various government agencies are used as input for policies, which I will also discuss with you what policies came out from this data analysis. So next slide. So all right. So just the next, I think, 5 or 6 slides will be basically slides showing you data that are being collected. So I won't really be able, because of the time limit, I won't be able to really delve in it deeply. So I'll just probably um, uh, uh, discuss the most important points. But I think we can give the copy to the secretariat, and then they can maybe just distribute this for those who are really more interested into the details. And also, I have to say that this data are actually generated daily, so we have daily reports. So the data that I'll be showing here are data that was collected up to October 4. So there's basically this all of these are have changed, and so this is the way how we evaluate and use all this analysis to inform our policies. So as of October 4, in terms of the Filipinos who are overseas, um, we have a total of over 10,000 Filipinos confirmed cases in 79 countries with COVID. Of them, 9,756 are still alive, and we have reported 793 deaths. You will see the distribution. Majority is in of the cases that we have gathered from, especially from our posts, our embassies and foreign service posts, which is our embassies and our consulate, are in the Middle East and African region. Uh, of so this report is actually a report based on DFA and DOH data. You would see that out of the 10,549, around 23% of that, over 2,400, were verified through the uh, IHR registry, which is basically the International Health Regulation. So there's a specific national focal point, which is the Epidemiology Bureau, that handles all this information. Um, I think important in this data is to show you that um, mm, the case fatality rate for those reported cases is 7.5%, which is seemingly high, because you'll see next slide. If you would next slide. If you would compare the case fatality rate for our, the COVID-19 cases that we have here in the Philippines, it's just 1.8%. So we believe that based on this data, that there's actually we haven't really gathered all of the Filipinos who are positive, or these are not really being reported in. And I think that's really one of the recommendations that you will see later on how we can institutionalize data gathering for overseas Filipinos, especially those who are affected by this pandemic. So next slide. So you'd see the Department of Health actually generates surveillance report among Filipinos staying overseas, but also we're generating reports on foreign nationals who are here in the Philippines who have COVID positive. So when we talk about migrants, we just don't look after overseas Filipinos. We also look at other types, typologies, what we call typologies of migrants, even the immigrants who are here or the foreign nationals who are here. So, in the October 4 report, for example, we have from based on the IHR, we have 2,414 reported cases, and then foreign nationals we have 329 foreign nationals who are here who have COVID-19. Next. So this is just giving you a flavor of the reports. So next slide that we generate. Next slide. Mm, yeah. All right. So basically, we report in terms of uh, migrants and overseas Filipinos. We have actually four case codes for this. So we report uh, OF, the source code OF. These are COVID-19 cases among Filipinos who are overseas or abroad. So as I've told you, it's 2,414 based on the IHR data. We report COVID-19 cases among foreign nationals with tests done abroad and with history of travel here in the Philippines as FN. So we have 148. We report COVID-19 cases reported in the Philippines notifiable to IHRNFP or National Focal Point. We have 329 foreign nationals who are diagnosed with COVID here. And then we also report recently the COVID-19 cases among returning overseas Filipinos detected in points of entries. So, those who are returning and they have the test in the airport. So, we have already a total of 8,676 cases. So, uh, yes. Next slide. So this one, we you can see here. This is a report generated by our Bureau of Quarantine regarding the returning overseas Filipinos in terms of the date of arrival. So far, about over 400,000 Filipinos have returned from overseas. Uh, Majority of them are land based, so you can see the land based, and we classify them as land based and sea based. Over 180, we have 108, almost 185,000 sea based or seafarers who have returned back to the Philippines, and we also have uh, are reporting transferees from Sabah, from Sabah, and then they go back to some via Zamboanga City. So this is the total 415,000. Next. Also of the report, so we also uh, report those who are positive and those who have recovered. So you can see that the among the returning overseas Filipinos, the 8,400 plus who became positive, this is 2.31% positivity rate. Uh, it so For your information, our positivity rate here in the country is about 10.2% currently. So this is also not the data. Just saying that the data for overseas Filipinos and migrants are not similar to the ones that we have here in the Philippines. And yes, and then we also on the right side, sorry, previous slide, on the right side of the screen, we also report, returning overseas Filipinos who are deceased. So although a lot of them, a majority of them are non-COVID cases, there are some of this who are returning to the Philippines, COVID are COVID-19 related deaths. So from February 1 to October 4, we had about 70% of all the total repatriations of human remains are COVID-19 related deaths. Next slide. So these are just to give you a flavor of what we are getting, and then the surveillance reports, also for medical repatriations. So next slide. Uh, So because of the data that we're collecting, we were able to incorporate this in the relevant policies that were issued. So I will not go through all of them, but just to note that these are the policies. Some policies, the DMs are from the Department of Health, the memorandum circulars from BOQ. There are joint administrative orders, all basically related. So these policies are relevant only for migrants and overseas Filipinos. So next slide. And then we have also IATF resolutions, like say for example this resolution establishing a subtask unit for repatriation of overseas Filipinos, and also joint circulars with other agencies. So um, the last one is latest one is a national task force order on the operational guidelines on the management of returning overseas Filipinos. So to summarize, it's basically we, because of the data that we have collected, this has inputs, this formed evidence in terms of the policies that were issued. We have tracked a total of 15 policies that are COVID-19 related. For specifically for migrants and overseas Filipinos. So the I mean, in terms of the efforts, this policy is actually translated to a lot of efforts on ensuring health services continuity for migrants and overseas Filipinos. So I lumped it into three main efforts or points for action. The first one that the DOH did was on the surveillance of the COVID positives among overseas Filipinos. So you see the slide on the coordination with the DFA, and also the one with the quarantine up of the among returning overseas Filipinos. The second point of action is on the repatriation and the management of returning overseas Filipinos, which has very specific task group. There were also deployment of medical teams during the initial phase of COVID-19, when we had to repatriate those from Wuhan, those from Diamond Princess, Grand Princess, mainly the cruise ships which had positive COVID cases on board. And of course, the third pillar of action is mainly lodged on medical assistance and coordination of care for overseas Filipinos, especially those who are returning. Although we have a program for that, which we call the Interagency Medical Repatriation Assistance Program, um, we had some of the programs had to be created, like say for example the establishment of the telemental health response, the one hospital command center, which also helped us in the continuity of care of especially for those who are returning overseas Filipinos. I know I don't have time, so I think in just to conclude and for some recommendations. So, what we did in this policy research is basically gather the evidence for so that policy will be informed and specific actions be taken. So the secondary data reported by various agencies are really important inputs for policy making during pandemics. There is a need for sharing and harmonization of data among various agencies for evidence-informed action and response. Data collection with regard to health of overseas Filipinos should be institutionalized, and all these lessons from COVID-19 should be used for subsequent planning. So I think I end that. I'm sorry for taking a bit of the more time. So I turn you over to Michelle.
Okay, thank you very much, sir, for that comprehensive and informative presentation. It is kind of reassuring that the Philippine government is continuously protecting and assisting the overseas Filipino workers and the migrants living outside the Philippines that are expected to be affected by this pandemic action, sir. Okay, we now open the floor for the reaction of Mr. Jerome Alcantara. Mr. Jerome Alcantara, currently the Executive Director of BLAS of OPLE Policy Center and Training Institute. Welcome to the forum, Mr. Alcantara. Good afternoon, sir.
Hello, good afternoon. Thank you very much for inviting us. And I would like to congratulate DOH and the organizers for putting together the conference. We're very happy to be part of this. And this is very timely because some of us may know market markets overseas are now gearing to reopen. And what we want to do is we want to utilize the data and the information that are being presented to us in order for us to build a better normal in terms of labor migration management for our overseas Filipino workers. What we have noticed so far is that quite understand most of the policies, programs, and approaches are mostly reactive at this stage. Parang pumapatay lang muna tayo ng sunog, ano? Kailangan ng tulong ng mga repatriated OFWs. So there is a need for us to establish health protocols for their return. So puro ganun yung nakikita natin in terms of policies. And that's understandable at this early stage. But now, as markets are starting to reopen, there is a need for us to identify areas for deeper investigation, both for research and policy. And for us at the OPLE Center, the theme moving forward really is integrating and highlighting health concerns and issues in existing labor management policies and practices, and in our bilateral and multilateral relationships with host countries. Ang holy grail po talaga naman ng mga OFWs at ng mga advocates for the rights of our OFWs is the portability of access to quality healthcare and health insurance. That's actually what we are, parang yun yung ano namin, ano, yun yung pinaka-objective talaga, pinaka-target. And one of the things that we should always consider when we're talking about OFWs and their families is that unlike other sectors, kapag sinabing OFW services, programs, it's not just the responsibility of the Philippine government, but it is also the responsibility of the host country. That's how our international regimes are built, no? That there's a shared responsibility between the host and the receiving countries. And also, for overseas Filipino workers, we also have to realize that there is a huge responsibility on the part of the private recruitment agencies and their foreign recruitment counterparts. So that should also factor in when we talk about gathering data and also crafting policies moving forward as we try to build a better normal. So I'll go quickly into some of the major themes that we have identified on the issue. First is that there is the importance in integrating health concerns into labor market analysis and monitoring. Because as I mentioned, in reality, it's not just the responsibility of the Philippine government, but also of the country of employment to ensure access to quality health services for the migrant workers. So what we're seeing is that there might be a need for us to use the data for a full re-evaluation of our deployment policies once job markets reopen, to include analysis on vulnerabilities of workers to COVID and other diseases. Very interesting po if we dive deeper into the data presented to us by Doc Joel, makikita natin marami doon sa Middle East, ano? And most of the deployment in the Middle East are in the elementary occupations, domestic work, and other similar occupations. So is there a correlation between the nature vulnerabilities and ano yung vulnerabilities na yon? That would guide us in the future when we're trying to open up, when we're trying to negotiate bilateral and multilateral bilateral agreements with host countries. No, baka we might consider coming up with negotiating points that would limit the vulnerability of our workers doon sa mga established na mga labor conditions ng mga workers natin. I also want to point out, to stress on the role of the private sector. So far, what we have noticed is that foreign recruitment, private recruitment agencies and employers are very much silent, not only in terms of reporting cases, but also on the actual provision of assistance. Remember that they are dated by law. Actually, meron silang atas galing sa batas na dapat ikatulong sila nangangalaga sa kapakanan ng mga OFWs. We are also very much concerned about, and we also suggest that we also take closer look at what will be the impact in terms of healthcare cost for migrant workers as labor markets reopen. We anticipate that some countries, as they open their borders, may require more stringent testing and may actually use this as opportunities to strengthen their cartelization of testing regimes. Baka po i-jack up yung prices, and we know that the higher the deployment cost, including the cost of testing for OFWs, there is a higher possibility of vulnerability. Lastly, we want to, on the access to immediate service at the post and upon repatriation, we also want to look at monitoring of health conditions after community reintegration. Our country's economy and health system will be overburdened this next few months because of the returning overseas Filipino workers. There are now, I don't have the exact details right now, but there are more than 200,000 plus workers who have already returned. And there are 700,000 plus estimated OFWs who will be losing their jobs because of their pandemic. So it's not just a matter of them the healthcare on infection, COVID and stuff, but also in terms of their mental health and in terms of their medical and health conditions, especially as they try to cope with the increasing hardships as they return and as they try to find a better life and for themselves and their families here. So those are our major points that we want to stress given the very limited time. We hope that future versions of data gathering will look at this, and that we will be using this not just on a reactive manner, but also to try to be more proactive and shape a better migration policy for the Philippines and our migrant workers and their families. So thank you.
Thank you, Mr. Jerome Alcantara, for raising really good points in how we can further protect our overseas Filipino workers and migrants living outside the country. I just want to concur with your statement po that we can use the vulnerabilities that we have identified right now in growing agreements with other countries, growing bilateral and multilateral agreements. Thank you so much. Okay, we're now in the question and answer portion. Dr. Joel Benaventura, sir, we will be entertaining 3 questions. The first question is there a need for a coherent policy across different government agencies, including LGUs, to avoid returning OFWs to be stranded and ultimately facilitate a relatively safer travels for them?
I think yes. So I think that's what they tried to address in one of the I think since I did not dwell much on the policies, there's actually a policy on the it's an NTF, the last policy, the NTF guidelines sets out an operational guidelines on the management of returning overseas Filipinos. So I think this is a lot of it is covered on this, and as well as in terms of like I think it's somehow related also to the testing. We have also the updated interim guidelines on the expanded testing for COVID-19, which includes also the returning overseas Filipino. So I think in terms of policies there are, but I think always as we see naman from what we've been seeing in the news, that it's really the implementation, and I think it's also part of the devolution of the health system that we have. So national government agencies are there to provide the policies, but the actual implementation will especially for the health side is really devolved to the local government units. Yeah. So I think it also answers the question someone put in the chat. Is there a joint guideline? So in addressing returning OFWs, yes. Yeah, those are guidelines. I'd be happy to share the slides. I think it's okay to share the slides.
or probably, sir, we can include that as we share the presentation materials today.
All right. Yeah.
Okay. Sir, thank you for answering the question. There's another question po from Mr. Marcelo Miguel and Miss Lourdes Risa Yapchong po. The question is, does DOH have the data on the breakdown as to age group and other demographics of the COVID-19 infected Filipinos in the 79 countries?
Mm, Um, yes, we have that, but in terms of I think the age, the sex, yes, we can definitely get that from the database. About the professions, this is something that we were not able to gather. So basically, there are some reporting, but this is not a data that it's complete, so we cannot actually report in terms of the professions. We actually are very interested to know, like say for example, here in the Philippines, we report how many healthcare workers are infected with COVID, but for the overseas, we cannot do that because I mean we don't I mean for the Department of Health, we don't have any presence uh in our overseas. So basically, we usually just rely on the data from the DFA, from our foreign service posts. So yeah, so that's why I think one of the recommendations is really to institutionalize, data gathering for this, so that like say for example, what Ma'am Lourdes has said, like we can include professions there. So yeah.
Okay, thank you. One last question, Doc. This is from Miss Kathleen Grace Lentija. The question is, did the study attempt to explore the conditions of undocumented OFWs? Is there any data available?
Um, for that, I think in terms of the scope of the study, it's really more based on the administrative data that is currently being produced. But I think in terms of the qualitative aspect of things, it's not the scope of this study. I think yeah, I would like to hear actually more on that if there will be an additional study. But as I've presented in the methods, the what we use mainly for as input for policies is are the data, the organizational data that are being reported, which I've shown you. Yeah, me. Yeah, maybe Michelle, I'd like to answer. I think there was a question, related question to the other one from Marcelo Miguel on the breakdown of the age group where COVID-19. So age group we can also calculate that from our database. Uh,
Okay.
yeah.
Okay. So can we entertain or accommodate one more question? This is the question
Okay.
from Ms. Maria Teresa Abola. The question is there a need to develop a standardized guideline on cardiovascular screening for those applying for overseas employment?
Um, in terms of screening, I think there is currently uh maybe someone from our health facility services regulatory bureau, because I know we have basic PEME, the pre-employment medical examination. So this examination is taken by our overseas Filipinos because before they leave the country. However, I know there are basic tests. I'm not so familiar with the detail in terms of like cardiovascular, but I think it should be there somewhere because uh like I mean it's not like everyone should do that. So because like if I'm a 20-year-old, seafarer, maybe I'll just do the basic test. But if I'm maybe on the 50s or the 60s, then the routine tests are different. So I think uh the basic pre-employment medical examination can be improved, but it should be, I believe it should be patient centered.
Okay. Doc, is it okay po if we're going to entertain one last question? Okay.
Daming question. Okay.
Okay, yes po, last na po
Sige
talaga.
pa, aba.
Okay. The question is there a guidelines in place also for OFWs wanting to return to overseas work?
Um, yeah. So far, with regard, thank you for that question. I think that's very relevant, especially now that we're opening up, the economy. There's actually, for that specific question, there's a I'm involved in the sub technical working group actually on travel. So this includes outbound travel for Filipinos. We currently the IATF guidelines actually allows for travel for returning to work of overseas Filipinos, but it just needs to have like certain criteria in terms of like of course it has to follow like certain criteria on the uh, necessary documents that they have to produce, and also noting that there are also regulations that are imposed by the country of destination where they are going to, so they have to follow all that. But I think we in principle we basically allow this, and we will I think it's just special for the tourists, like more of those who will be traveling for leisure. I think there are certain guidelines in terms of the insurance that you need to have, so like it has to cover like if in case you will get COVID-19 for abroad. So I think we are putting some of these elements so that you would be at the end protected as well.
Okay. Thank you, Doc, for further enlightening us with your answers to the questions raised by our participants. We thank you for sharing your expertise with us this afternoon. Thank you so much,
Yes,
Doc.
I will try to answer also in the chat those who have. I see a lot of questions. I know when it's about migrants, our OFW, our bagong bayani, you
Actually, Doc,
expect a lot of
yes,
a
yes.
lot of questions. So
There's a
I'll try to
participant
answer.
po asking for
Uh,
your number.
uh
Maybe she has very important questions. Thank
maybe
you, Doc.
I can flash the last slide on the this one. So this is, you can email po if with regard, just put it's from this conference, and then you can contact these numbers.
Okay. Thank
All
you.
right.
Then
Thank you.
the first presentation. Thank you so
Thank you,
much.
Michelle.
Okay, we will be back shortly after the 5-minute break. Okay. Coming up next, the second presentation. Okay, and we're back. We will proceed to the second presentation entitled Wave 4 Survey of the Longitudinal Cohort Study on the Filipino Child, children aged 19, 10 to 13 years old. As we all know very well, the children belong to this age bracket. We consider them as adolescent rather, and we know very well that in adolescent stage, this is a period of change characterized by cognitive, psychosocial, and emotional development. Disruptive events during the critical life stage and during this critical life stage may lead to lifelong mental disorder for adolescents. So it is important that we understand the various underlying factors that drive or mitigate potential problems associated with their mental health, especially in the context of the COVID-19 pandemic, where situations are expected to worsen. To give us more information regarding the study, Dr. Charles Andro Bautista will be joining us today. Dr. Bautista is coordinator of the cohort study project coordinator at the United Nations Population Fund. Welcome to the forum, Dr. Bautista.
Hello, good afternoon. Can you hear me?
Yes, Doc. Loud,
All right,
clear.
all right, thank you. So I'll just make a quick correction on the title. So what I'll be presenting more is on the wave two of the study. So the children by this time are 11 years old. So before we proceed, um, I would like to provide an overview of the study. I would just like to give a caveat that this is a really big study. This is a collaboration between the Philippine government, the United Nations, and also the Australian government. And our researchers is made up from a consortium of researchers from the University of San Carlos, University of the Philippines, and Xavier University. So I'm just presenting the study, but we are a very big team conducting this 15-year study. So what is the longitudinal cohort study on the Filipino child? It's basically a age cohort study whose goal is to be able to examine how the sustainable development goals will influence the lives of young people from when they are 10 years old until they turn 24. So we are looking in a prospectively observe a nationally representative cohort of 10-year-olds way back in 2016, and we are following them up annually until 2030. Next slide, please. So this is the framework that we're implementing in the study. So we're basically collecting data from the community, from the households, and from the index children themselves. And we're trying to look into the interrelationship between the SDGs, the ecosystem, and the target population. So we look at community factors such as barangay characteristics, existing health programs, facilities, exposure to disaster, and see how it affects your household factors, and see how eventually how it trickles down to the index child, how it affects his or her schoolwork, physical, mental health, knowledge, risk exposures, etc. And we're tracking this way back from when they are 10 until they are 24 years old in 2030. So we're actually tracking key milestones in the lives of these cohort participants. So we started at around 5,000, and hopefully by the year 2030, we have 2,000 of the cohort remaining at least. And we're looking into the prenatal transition, sexual experiences, their educational experience, entry to labor force, marriage, parenthood, basically key milestone as they journey through the 15 years. So the focus of my presentation will be to highlight some of the key findings that we got in wave 2 when they were 11 years old on cognitive ability, social competencies, mental behavioral functioning, and corresponding significant correlates. So to begin with, just as background, by this time, the data was collected in 2018. The children are now 11 years old. And when you look at their pubertal maturation stage, most of them has begun or at the middle of their pubertal transition. So this goes for both boys and girls. So this is very important because puberty, as we know, is an important period in an adolescent's mental health development. In particular, puberty is a transition period where the child starts to get and assume more responsibilities. Puberty is a period of rapid developmental growth, both physical, cognitive, and psychosocial, and all of three are interrelated. And we would like to highlight that pubertal transition differs by sex and is affected by their health status. So not everyone goes through puberty um, at the same rate or has the same pubertal transition experience. And this is something worth looking into. So at age 11, from the cohort, so this is basically their social demographic profile where most of them are somewhere around, when we collected the data, around 10 to 12 years old. And we would like to highlight that about 90% of the children that we interviewed were in their age appropriate levels in terms of schooling. So majority of them are in either grade 6 or grade 5 in wave 2 or in 2018. So before we would like to highlight some of the vulnerabilities that these children experience. So with regards to education and nutrition, what we're seeing, although when you look at the differences between wave 1 and wave 2, a lot of the indicators are improving, which is expected. But we noticed that in terms of education and nutrition, boys compared to girls are significantly more vulnerable. So more boys are stunted, more boys are exposed to hunger, and they have poorer school outcomes. And when we look at other vulnerabilities as like exposure to violence and even exposure to paid or unpaid work, boys are also more vulnerable. And when you look at the various risk factors like drinking alcohol, smoking, um, chatting with strangers in the internet or being able or watching pornographic movies. As expected, boys are at this particular age group. Boys tend to be more vulnerable compared to girls, and this is statistically significant. We would like to also show this. It's that because the internet use is something that's very prevalent now, that way back in 2018, at age 11, or more than half of our children at age 11 are already have access to the internet already. Majority are accessing them in internet cafes. And as you can see at the data, this has been significantly increasing year per year. And some preliminary data that we have at age 12, the access to internet is actually roughly at around 70%. And this is very important because once we look at into the especially the mental well-being of these children, access to information is something that has to be looked into, which we will discuss in the recommendations part. So for the next part of my slides, we already know based on the vulnerabilities that boys tend to perform a little bit worse compared to girls, but we wanted to be able to objectively measure this. And to be able to do this, the research team employed the Raven Standard Progressive Matrices in Wave 2 in 2018. So the RSPM is a 60-item test. It consists of diagrammatic puzzles developed by John Raven in the 1930s. And the reason for doing this is it meant to be a culture bias-free test, measures nonverbal and abstract reasoning, particularly because we know that if we just use schooling as an indicator, there's a lot of factors that actually come into why or why not a child will perform well in school. So among the 4,642 children who completed the test when they were an age 11, the mean score was around 29.5, and the scores range from 22 to 57, and we had one score at around 60. So what did you find out from the Ravens from the RSPM, from the Ravens test? So basically, once we analyze the data, that what we learned is that being male, being living in a rural area, or being, remember, all of these children at 11 years old, and at 11 being in a lower grade level is associated with lower cognitive scores. And we also tried to compare it across different island groups. And what we're seeing is that children in Visayas and Mindanao had lower cognitive test scores compared to those who are in Luzon. And this is consistent with other multivariate analysis that we ran with the data. So aside from the Ravens test, we also employed the child behavior checklist. So the CBCL was done to add a measure of the index children's social competencies and adaptive functioning from the point of view of their mothers or caregivers. So we'd like to emphasize that Raven's test was accomplished by the child. The CBCL is a checklist that is asked to the mother or the caregiver. So the CBCL is a tool that measures competency levels in terms of activity levels or social skills and school performance. So there are the syndrome scales, on the other hand, as part of the CBCL, represents internal factors emanating from within, external factors, and problem behaviors, unusual behaviors, attention seeking, and related problems. So when you talk about internalizing factors, these are reported behaviors that depict anxiety, depression, or other somatic complaints. And we talk about externalizing factors, we're talking more about things that are more visible, like rule breaking, aggressive behaviors. So we employed the child behavior checklist because we want to see the social and behavioral aspect of these children. So when we run the data, what we're seeing is that, interestingly, well, first, as expected, as shown by the Ravens test, um, girls girls in general has a higher um, school scale score compared to males, while on the other hand, males on the other hand scored higher in the social scale, and as mentioned earlier, it scored lower in the school scale. What this means is that significantly, in terms of behavior observed by the caregiver, boys tend to show better behavior in terms of socializing, while girls tend to perform better in terms of schooling. And lastly, from the CBCL, so when we're looking at the competency score, so the higher the score, the better. But when we talk about the syndrome score, the higher the score, the the worse the outcome is. So what we saw with the data is that in both internalizing and externalizing factors, boys tend to have higher problem syndrome scores. Meaning, in terms of internalizing factors, they're more likely to have experience to exhibit behavior of depression, anxiety. When we talk about externalizing factors, boys tend is more significantly tend to have behaviors showing aggression or rule breaking. So there. So that's basically the summary, the gist of the presentation. So in summary, what we'd like to highlight is that puberty is a critical period of rapid developmental growth. And what we're seeing is that in general, boys and those living in Visayas and Mindanao are exposed to more vulnerabilities and risks during early adolescence that might impact their cognitive and psychosocial development. At the same time, boys and those living in the Visayas and Mindanao also consequently have poorer cognitive and social/behavioral scores. So as a recommendation from the study, um, one thing that we have to note is that children experiencing puberty are exposed to various vulnerabilities, and we see this in the study, and therefore they should be targeted for intervention. So it's very important that we explore further what are their sources of information and what support do they get during this transition period. What if there are any available programs designed to help children at this stage. Other things that we have to look into is that children's cognitive ability is an important pillar in their human capital formation. And one of the thrust of the Philippine government now is to attain the demographic dividend, and investment in human capital, especially on young people, is critical for this to be achieved. And the question with moving forward is, how can we help these children who are cognitively vulnerable to provide them with better prospects for the future? The CBCL results describe the children's behavioral emotional profile and total competency. And once we look into the data, how can we use this data to inform and improve the welfare of children? I guess a question I know the reactor will be providing inputs. Are there any provisions in the Mental Health Act that can ensure wider coverage for this particular age group? And lastly, very significant in the study is that boys tend to appear at this particular age group disproportionately disadvantaged compared to girls. And there is a need to examine the content of gender socialization within households and in the curricula used in the basic education. And before I end, because of our current context in COVID-19, although we say that it is the elderly that's more affected in terms of health outcomes, they're more likely to experience mortality. We have to take in consideration the impact of the pandemic also on young people, especially on their mental well-being. And this is something that we're looking into right now. So basically, that's the end of my presentation. We would just like to put this forward that if you have any questions or queries about the study, and also we're actually opening up the access to the data to prospective researchers, if you want to be able to access the data, please don't hesitate to email me at this email. And before I end, we like to also say that we're actually releasing 6 policy notes this year for publication this year, and hopefully you get to also access them. They're very interesting, especially the one on child work and labor. So that's the end of my presentation. Thank you very much.
Thank you for that very comprehensive, informative presentation, Dr. Bautista. We're looking forward for the next publications. The mentioned earlier, the 6 policy notes that you're intending to publicize this year. Okay, we're now opening the floor for the reaction of Ms. Frances Priscilla Cuevas Mompresi. Mompresi is the Chief Health Program Officer at the Disease Prevention and Control Bureau of the Department of Health. Good afternoon, ma'am.
Good afternoon. Can you hear me?
Yes, well, loud and clear.
Okay, thank you. For a while, I was cut off and I was panicking already. Okay, so thank you so much, Dr. Bautista, for that very well done presentation on the cohort study that you did on the Filipino child. And indeed, it will be very interesting to see the results in 2030. Sana makita pa natin yung mga results na yan. As we all know, we are only looking at the results of wave 1 and wave 2. And the results showed that indeed these children are being exposed to various vulnerabilities, and it is very important that they are being addressed. Of course, what comes to mind immediately is that the social determinants and vulnerabilities that these children are being exposed to are actually not just the responsibility of the health sector. Of course, the whole of government and the whole of society approach should really be mobilized so that all of these children, all of these social determinants, vulnerabilities can be addressed accordingly. The Department of Health, as we all know, it has an adolescent health and development program, which is lodged under the Disease Prevention and Control Bureau and has been providing health services to adolescents. It uses the HEADS assessment tool that seeks to understand the different risk factors that they are being exposed to, and using that, they are able to provide a package of services that are designed accordingly to address their very specific needs according to the result of the assessment tool. However, the result of the study that you did put the National Mental Health Program into focus, and I would like to say that I would like to thank you for the opportunity to look at how we are doing our National Mental Health Program in terms of really focusing on children and adolescents, and how the mental health of these children are also being addressed. I agree with your recommendations that we need to be able to review the Mental Health Act. The Mental Health Act is an act which does not discriminate. It did not actually refer to any age group, but is really referring to the population regardless of age range or groupings or vulnerabilities. But what we are saying now is that even if it did not put in specifics or specificities on how we should approach addressing the vulnerabilities that these children are being exposed to, I think it's incumbent upon us that as we operationalize our strategic plan, which the Philippine Council for Mental Health already has done and is now being rolled out for implementation, we need to be able to put a little bit more of focus, actually laser focus on the specific interventions that we should be putting in place. Of course, the law also mandates the school, the institutions, particularly DepEd, to take a look at the different interventions that they need to do in order to focus on the mental health and wellness and promote mental health in the school children. But there might be some areas there that we need to really work on. In particular, what caught my attention in the report is the fact that the boys are particularly vulnerable, and those who are actually living in the Visayas and Mindanao are exposed to more vulnerabilities and risks. Could we get maybe we can talk about later on, the specifics of this. What are these vulnerabilities? Why is it that boys and those who are living in the Visayas in Mindanao are a little bit disadvantaged with regards to or in comparison with their peers in other places and gender? We need to be able to see all of those because there are probably areas there where we can specifically also intervene. I would like to say that in the end, I just would like to highlight what the Lancet Commission on Global Mental Health and Sustainable Development report in October 2018 or recommended, that we should look at reframing our mindset on how we look at mental health. So let's look at it from the point of view of mental health. It says there that we need to be able to reconcile the nurture debate by converging the findings of social and biological determinants of mental health problems on life course trajectory or neurodevelopmental neurodevelopmental areas. What it means to say is that we are not only looking at how we nurture our children, but we are also going to be looking at what are the social and biological determinants that are actually influencing them in terms of their mental health. So nurture and the determinants of health is very important when it comes to reframing our minds on looking at how we can look at and how we can intervene for the mental health of these people. So again, I would like to say thank you to you and to the results of the study, and we know that you are working on the next wave, I think.
Yes.
And we look forward to the continuing results of this study. Thank you so much.
Thank you so much also.
Thank you so much, Ms. Pressy, for raising very those questions that need to be answered. Actually, our participants are asking the same questions, the questions that you've mentioned that should be answered. Okay, Dr. Drew, we will be entertaining 5 questions po.
Yes.
Okay, the first question is, can you cite some factors, either external and external factors affecting the cognitive development of boys in Mindanao?
Yes. So, well, basically from our study, we're not able to really isolate which particular are contributory to the differences, but we would like to assume there are a lot of social and demographic factors that affects it. Something that we need to actually look into moving forward, one would be the socialization. Like, remember, we at this particular age group, it's very crucial. It's a crucial time when basically gender identity is being put in these children. What are the expectations among these children? So we don't know if how much that impacts the development of the child. we also have to look into if it's really more biological, but I think it would be more social or and more cultural than actually biological. But of course, with right now, admittedly, we still have to look into that. But definitely, when you talk about Mindanao and Visayas, we know that for a fact that in terms of social demographic characteristics, definitely people living in Luzon are in generally um, living in better conditions, and we have to also take into consideration the experience of children, especially in Mindanao, those who are, because we're also capturing children from BARM. So we don't know if the experience, because this is 2018. So if we don't know if the experience of armed conflict also has something to do with the differences. And also, just to highlight, also Mindanao has more rural children compared to Luzon. Majority of those living in Luzon are actually living in urban areas.
Okay. Okay, thank you, Doc, for raising those possible factors why boys in Mindanao and Visayas are more at the disadvantaged sides. Probably this could drive for further research. Okay, um, we are going to proceed both to the next question. This question is from Mr. Leonardo Alcantara. The question is the economic status of families and educational background of parents a factor in cognitive performance of children in the cohort?
Yes. So definitely, these are basically all of the three things are in a way correlated. But we have, well, admittedly, we haven't run it specifically, but definitely because we expect that those who are living in poor areas tend to perform worse. Yeah. I'll double check now. The- Sige, no, if you could go on to the next question first,
Okay,
then
okay.
I'll answer that more specifically.
Okay, thank you, Doc. And the third question is from Mr. Marcelo Miguel. The question is it was reported that crimes committed to children were observed during the pandemic. What measures should be implemented to avoid these effects of the pandemic? Dr. Bautista?
Can you repeat the question?
Okay. It was reported that crimes committed to children were observed during the pandemic. What measures should be implemented to avoid this effect?
Measures meaning like what the government should do to prevent this effect. Well, I think this would be a little bit outside of the research, but this is something more that we're looking into in UNFPA. One of the things that we noticed is that if you look at reporting data in terms of especially violence against women, violence against children, this actually has gone down during the pandemic. And this is more of a discussion between my colleagues, is that one of the things that we're looking into is that one of the sources of reporting for violence against children are teachers. Now that the children are at home, so that's actually just a very difficult question to answer. Like, I don't really know what the answer at this point, but very least I think we need to be able to put in the safety mechanisms as to how to protect these children from abuse, especially that now they're just at home. There's no one else to actually who sees what's happening, the dynamics between the parents and the child. Also, going back to the previous question, we look the data. What the data shows is that socioeconomic status and in particular the education of the mother are protective factors for a lot of these vulnerabilities. So if the mother is actually more educated, and we know that's also correlated with the socioeconomic status, they tend to have better vulnerability scores.
Okay, thank you for answering that question, Doc. We're going to entertain one last question po. This question is from Ms. Annabelle Rebollido. The question is, our government is aiming to provide free national internet services. Do you think this move will increase the vulnerability of children, such as risk taking behaviors, cyberbullying, exposure to social media, etc.?
Um, okay, so will the government provide? I don't know. Maybe Miss Percy could actually be more knowledgeable if government will provide. But in terms of vulnerabilities, I think the point here is not so much, it's not the access to internet that's a problem. It's really how the parents will be able to control the media or the content that their children receive from the internet. I think that's the bigger issue. So yeah, that's my short answer to it. So because now as more children have access to the internet, especially that it's required for school, the question now is how do now parents actually in a way not control but in a way be able to really manage this. Do they know what sites children go to? Do they know that what where data shows that around 20 or 30% of children actually talk to strangers online? Do they know the conversations that the children has? So those are the things that we need to think about. Maybe if we could have guidelines for kids and parents on how they could actually manage it, especially during COVID, that would be, I think, very helpful.
Okay, thank you. I think, Mom Pressy, perhaps you would like to add to the
Uh,
explanation of Dr. Bautista.
mm, Again, Dr. Bautista was saying it's a very hard question to answer at this point in time. I think um, there's yeah I would like I tend to agree, and I would like to agree that there is really a need to have guidelines and safety nets, no, that we need to put in place for children to be not to be subjected or not to be exposed to all of these atrocities that are brought about by the use of internet and the web and the web world or whatever. What I'm saying is that it's not actually the wife. It's not actually the internet itself per se, but it's really how parents would protect the children, and how they would usually have time, to take care of the needs of their children. And I think the COVID pandemic has really brought about our inadequacies on these areas, and because more people now are in the homes. um, the current situation has brought about actually how weak we are in our own homes, how we were not actually able to really look into the lives of our children and really look at their own needs. And it's only now that we are hurrying up to putting up all of the safety nets that we need to be able to do. But then again, having said that, that we are ill prepared actually to have all of these things in place, then these are things na kailangan nating habulin siguro na dapat gagawin, no? And the COVID pandemic is going to be with us for quite a while, and it's not probably too late, to put all of these safeguards and safety nets for our families and for our society. Yes, but thank you for bringing that up, because those are very important areas I think that we need to put focus on. That's right. Sometimes you need all of these forum and all of these discussions to bring home some point that should have been neglected, could have been neglected if not for these discussions. Thank you.
You'd like to add lang din that teachers also play an important role as they are a major source of information for these children, especially in terms of accessing the internet for school. They will be the ones who are guiding the children as to which particular websites to go to, etc.
Yeah.
So I think teachers need to be supported also and guided as to how to manage this issue.
Yeah.
Okay, I think for the parents listening right now, the things you've mentioned, actually, they are parang practical tips that they can follow or they can consider in guiding their children during this quarantine period. Thank you so much. Um, I think that's the end of the Q&A portion of this presentation. Thank you very much for sharing your expertise with us, Dr. Bautista and Ms. Priscilla Cuevas. Thank you. Good afternoon. After this, we will be having the 5-minute break. Oo nga, sir. Mas mabilis pa tayo ngayon.
Hello.
we're back. Before we proceed to the next set of presentation, let me just welcome the participants who just checked into the platform. Good afternoon. The next set of presentation will be focusing on the elderly. The first, the third presentation will be presented by Dr. Shelly Ann de la Vega using the framework on healthy aging, the focus interventions for frail older persons, fit for frail study sought to understand the elements of intrinsic capacity, that is the health status of older persons, and its interaction with the environment, such as health systems, the social, and the physical. In the study, comprehensive geriatric assessment and health systems evaluation were used to assess the health service delivery for the older persons in the country. To hear more on the results and the analysis of the assessment, let's call in Dr. De La Vega.
Good
Welcome to the forum.
afternoon.
Yes,
Good afternoon.
welcome.
Thank you
Welcome to
very
the forum
much.
for Dr. Shali Ann de la Vega is the current director of Institute on Aging, National Institute of Health, University of the Philippines, Manila. She is a professor at the College of Public Health, University of the Philippines, Manila. The floor is yours, Dr. Shali Ann.
Thank you very much, Ms. Michelle. I am Professor 6 of the UP College of Medicine. So thank you very much to the organizers of this forum, especially our funders, DOH AHEAD, HPSR, PCHRD, and our partners. I'm Dr. Shelly De La Vega, and we will talk about COVID-19, a call to strengthen universal health care to address the needs of Filipino older persons. So, next slide. As a background, the COVID-19 pandemic has become a global public health challenge, especially in low and middle income countries. Most affected are older persons, or OPs, and those countries with weaker health systems. Epidemiological data shows that there are more than 32.7 million confirmed cases globally. In the Philippines, more than 304,000 cases and 5,344 deaths were reported as of 27 September 2020. Excess mortality are reported all around the world among older persons, about 10 to 12% worldwide, and about 63.9% in the Philippines, with a ratio of deaths among older persons aged 80 and older are the highest. Next slide. Older persons and people with pre-existing medical conditions such as hypertension, diabetes, and obesity are more vulnerable and have a higher risk of death from COVID. Furthermore, COVID quarantine increased the risk of mental health problems such as anxiety, depression, cognitive decline, social isolation, neglect, and abuse. Fear, stress, and loneliness face older persons and affect their resilience and further jeopardize their well-being. Next slide. In addition, older persons are not able to access usual care for treatment of their pre-existing medical conditions. Disruptions in usual care, such as medication management due to lockdowns, compel older persons to rely on less healthy options or completely neglect these medical needs. Allocation of health services to focus on COVID-19 cases has left other necessary services with insufficient funds and health manpower. Next slide. So restating the problem, the Philippines has an increasing aging population. I think we're almost 8 million older persons now. And older persons are prone to complications and adverse outcomes during pandemics and disasters. The current pandemic has highlighted the vulnerabilities also of the health system, and not just older persons in particular, and its readiness for providing equitable and quality services for older persons. Next slide. So this is Fit for Frail, our project, and it is a research project of the Institute on Aging, NIH UP Manila, funded by the DOH through PCHRD, using the WHO framework on healthy aging The objectives of the project are to identify what and how existing health systems are aligned in preparation for the WHO Healthy Aging Framework and the DOH Healthy Aging, to describe the health status of older adults and describe the prevalence of frailty in select communities, and this is what we call intrinsic capacity, and to identify interdisciplinary socio-cultural and medical solutions to achieve healthy aging with a focus on the vulnerable, frail, older persons. But what is healthy aging? Next slide, please. Healthy aging is defined as the process of developing and maintaining the functional ability that enables well-being in older age. Functional ability in this light is the interaction between the intrinsic capacity or health status and environmental factors. It is viewed through a life course perspective, wherein an individual accumulates strengths and deficits across the life course. So it's also important for us to view the aging child as presented earlier by the Cebu nutritional study or longitudinal study on nutrition. So it's very important that we also look at the healthy mother and the healthy infant, because all of them, as they grow older, will become healthy adults and healthy older persons. Furthermore, the WHO has declared 2020 to 2030 as the decade of healthy aging. So we have entered the decade of healthy aging. Next slide, please. So let's introduce the methodology of the Fit for Frail using the Healthy Aging Framework. Through a mixed methods approach, we analyze the following intrinsic factors: the environment, and another output is research capacity and development. Fit for Frail is an interdisciplinary and participatory research. It highlights the involvement of the community through many activities, orientation to discussion of the questions that we are going to ask, to piloting of the collection tools. We involved in the process older persons, senior citizen office, the OSCAs, the federations and senior citizen organizations, officials, such as mayors, barangay captains, nutrition scholars, health workers, barangay health workers. We also convened an advisory board regularly, and our advisory board includes representatives from DOH, DSWD, NEDA, COSE, and the PhilHealth. Next slide, please. So this is the healthy system framework that Study 1 of Fit for Frail used. We use the building blocks, namely health service delivery, workforce, information systems, access to essential medicines, financing, and governance. Next slide. So this is how we collected our data. Again, mixed methods were used, as you can see. KII, FGDs, listing of services, and case studies. And we visited sites and participants from 27 DOH retained hospitals that were identified to become or to host geriatric centers. And within their catchment area, went to 17 health centers. Case studies were done in the NCR and Region 4A, one private and one government facility each. A survey on utilization of health services was conducted on 30 older persons in the nearby communities in these case study areas. Next slide. Let's discuss study 2 briefly. Next slide. So these are the criteria for study site selection. Independent listing and mapping was performed. The cleaned and validated lists underwent stratified random sampling to get the recruitment list. Next slide. So our inclusion criteria were as follows. Very, very simple, really. Age 60 and over, living in the vicinity of the identified community, and able to communicate, respond to questions, and consent to the study. Next slide, please. So this is how we collected our data. Health data for the intrinsic factor were collected primarily through the comprehensive geriatric assessment, which is a tool that we geriatricians used. And we used the research version. It has been translated, validated, and piloted into 3 languages. Trained health professionals, who were our research assistants, interviewed the participants and assessed their function, quality of life, cognition, nutritional status, using standardized and translated screening tools. Next slide, please. Physicians did the physical and neurological exam. They were trained in the methodology, and the final diagnosis were adjudicated by a senior geriatrician. Oral health professionals were trained using the WHO methods of oral health assessment. Those who were unable to come to the study site were visited at home, so we did home visits. Laboratory blood tests were also performed. Next slide. We also had a qualitative method in which our co-investigator, a medical anthropologist, chose study 2 participants in each municipality. 6 participants were randomly drawn and stratified according to sex and frailty status. Frailty was identified using the modified Freed criteria, and they were classified as either robust, pre-frail, and frail. Next slide, please. So results were analyzed by our statisticians using Stata 15.1. Next slide. Now, Fit for Frail, study 2 looked at targeted 424. However, we oversampled, looking at 990 participants, because we know that there is a low participation rate among older persons in such researches. For the comprehensive geriatric evaluation, our first visit, participation rate was 95.5%. There were several dropouts throughout the study, but their patient characteristics were not statistically different from the original study population. Next slide. So 87% of those who completed the comprehensive geriatric assessment underwent the physical exam. And like I said, despite the dropouts, there was no significant statistical difference between the starting population and the ending population. Now let's go to the socio-demographic profile. Next slide. So this is the socio-demographic profile. Most were females, young, old, aged 60 to 69 years. Many worked as housekeepers and were in agriculture. A few are still working as sellers or marketers. Next slide. Although many completed elementary education, as you can see, most completed high school and beyond. Majority were married, less than half had pensions, and a great majority received financial support, mainly from their children. However, 1/3 of the participants also helped support and care for other family members. So this was a cohort that took care of and were not totally dependent on others. Next slide. So now let's look at the medical risks. The CGA, or the Comprehensive Geriatric Assessment, adjudicated by our geriatricians, revealed the following diagnosis. Of the non-communicable diseases, or NCDs, that are associated with increased COVID morbidity and mortality, hypertension topped the list, followed by diabetes and obesity. Among the mental health problems, sleep problems or sleep disorders topped the list, followed by depression, dementia at 9.1%, and anxiety. Next slide, please. Now, look at the mental health research implications of Fit for Frail. If you can see in the chart, there were more reported symptoms of dementia and anxiety compared to participant-reported diagnosis. Geriatrician diagnosed dementia, anxiety, and Alzheimer's exceeded the participant-reported diagnosis. So it seemed like the participants were feeling and having these symptoms, but were not able to go to physicians for their proper diagnosis. Fortunately, during this study, our team were able to identify those who truly had dementia, anxiety, and Alzheimer's. Next slide, please. The same pattern is shown in this slide. With regards to sleep and depression, there were many newly recognized cognitive impairments because we did the Montreal Cognitive Assessment Screening. However, just as a caveat, MOCA does not tell you that you have dementia automatically if your score is low, and not everyone with cognitive impairment will eventually have dementia. Next slide. How about respiratory risks? Pneumonia and asthma were still in the top 10 participant-reported problems. When we asked about their lifestyle, these questions revealed that most participants have never smoked tobacco, which is good. However, 11.6% are currently smoking at the time of the interview, and most of them who are still smoking are men. Unfortunately, if you can look there, very few received pneumonia and flu vaccines. Next slide. Now let's go to frailty. Frailty is not a new concept, but it has been steadily, researchers have been quite interested in the frailty syndrome recently. Frailty is defined as reduced strength and physiological malfunctioning that predisposes an older person to increased dependency, vulnerability, and death. The frailest among the frail are at risk for COVID complications, hospitalizations, and death. So the Fit for Frail study, based on our CGA diagnosis, identified that 15% of our cohort were frail, especially those aged 80 years and older. However, if you look at the figures there, it is important to note that the majority were not frail. In fact, 19.3% were robust, and 60.5% were pre-frail. This is where medical, health system, and environmental interventions can work, because frailty is a dynamic state. It is preventable and reversible. Next slide. So our study also revealed that frailty is associated with the following conditions. Older age groups, as you know, as I've been mentioning earlier, weight loss, nutritional status, risk of falling based on our timed up and go and functional reach test, diseases and syndromes, geriatric syndromes such as dementia, arthritis, diabetes, neuropathy, cataract, and constipation. Symptoms of fatigue, cough, and numbness were also associated with frailty. Next slide. We identified that the oldest and highest risk group for frailty were those old or those aged 80 years and older. In our study, the oldest age group were also found to need assistance in activities of daily living, had poor functional ability, had a higher history of falling, were the most afraid of falling, had poor oral health and missing teeth, and were undernourished. And of course, frail. Next slide. Social functioning, we mentioned that earlier. Social and functional risks that were identified include social isolation. 4.2% were living alone, and dependency. 15.6% needed a primary caregiver. In particular, 44.2% of those aged 80 years and older were already in need of a primary caregiver. And mind you, when you look at studies on COVID deaths abroad, this cohort, 80 years and older, who need full assistance or a lot of assistance in their activities of daily living, were at the highest risk of mortality from COVID. Next slide. So let's look at study one, at our health systems report. Now, we have hospital services here listed. These are the services that improve health outcomes of hospitalized older persons. So we want hospital services to include discharge planning, rehabilitation, medication, reconciliation, and geriatric programs. It is good to know that a great majority of the facilities visited conducted these. Unfortunately, the facility visited in CAR, the Cordillera Autonomous Region, and Region 12, or SOC-Sargent, did not have a geriatric program. Next slide. How about the regional health units? Remember, we visited 17 partner RHUs. Unfortunately, although most facilities were able to provide free medical and dental checkup and psychological counseling, only 25% of the RHUs were able to provide geriatric assessment, or the CGA, and cognitive health evaluation. Next slide. So when we looked at their programs and papers and policies, we looked at their pandemic responsiveness. The facilities visited did not have a pandemic response specifically tailored for older persons. Of the 27 DOH regional hospitals identified to become geriatric centers, only 4 had functioning geriatric wards. Because of the pandemic, one ward had to be converted to a COVID ward. Fortunately, 2 facilities maintained a separate COVID ward for geriatric patients. As to the pre-pandemic services offered to older persons, majority of the services offered in these facilities were outpatient in nature. Next slide. As mentioned earlier, right? I think that was yesterday. Human resource is a very important component of health system. No, we can have wards, we can have beds, but if we don't have people who are dedicated to and trained to take care of older persons, then unfortunately service suffers. No? The Philippine College of Geriatric Medicine, of which I am a fellow, has 160 certified geriatricians for 8 million Filipino older persons. And the DOH Nurses Certification Program has trained 100 geriatric nurses. The Fit for Frail Services listing found out that there are not enough older person dedicated and trained nurses and doctors in regional hospitals, and none are available in RHUs. There are no psychologists, no psychometricians, no occupational therapists, and no pharmacists dedicated to geriatric patients in most hospitals, and none in all of the 7 RHUs that we visited. There were only a handful of nutritionists and dietitians and social workers. And we know that we need to take care of older persons as a team. And all of those that we have identified in this list are very important in the care of older persons. Next slide. We did an extensive paper and policy review. We have pages and pages of papers and policies, Republic Acts, specific policy briefs on COVID, plans and guidelines. We looked at these, and these are available. If we will publish these. Thank you very much to our hardworking team. So, next slide. In conclusion, older persons are at risk of COVID-19, and we need to respond to their needs. The establishment of quality geriatric programs and services will enable the health system to commit to healthy aging and respond better to challenges of older persons now, during disasters, and during this pandemic. Next slide. Based on our study, we present the following policy recommendations. First, to promote and enhance healthy aging programs, specifically the National Health and Wellness Program for senior citizens, focusing on geriatric assessment, fitness, nutrition, vaccination, enhanced services for mental health and frailty, align the delivery of these services of health facilities and RHUs with the universal health care, specifically to expedite the establishment of the identified geriatric centers and specialty centers in line with RA 9994 and PHDP 2020 to 2040. And of course, to ensure adequacy of human resource through salaries and capacity building of personnel dedicated to geriatric patients. Finally, establish national programs for disaster response and resilience. And I know that we now have a plan, an ongoing plan to have a resilience institute, I think, to support communities, their families, their caregivers, their barangays in the care for the frail and isolated older persons. No? I know that for Region 11, the barangay who we visited now are going to have a nutritional plan in order to provide good nutrition to those frail, homebound older persons who we have identified to be in need. Of course, because we are researchers, we need to conduct aging research, monitoring, and evaluation for the improvement of services and policies. Specifically for COVID, to analyze and disaggregate COVID data based on age groups. Now we have the young, old, middle, and old, and sex. And to develop COVID adaptation for community research. Thank you. Next slide. We would like to thank our team. Please, team, thank you very much. Study 1, Study 2 are study leaders, my co-investigator, our project assistants and clerks, our statisticians and statistical assistants, our advisory board members, our consultants, physicians, of course, our clerk, and of course, the geriatric team of doctors, and of course, PCHRD, DOH, and our partner barangays and organizations. Thank you very much to you. Next slide. And these are our partners, no? For participating in this research. We would like to announce that we will have a research, dissemination, and harmonization workshop for those of you who are with the DOH, CHD, R&D, and PCHRD regional consortia. We will
Thank you, Dr. Shally Ann de la Vega. Thank you for that comprehensive presentation. As to your Fit for Frail study, personally, I was affected by the presentation. As a young adult, it challenges me to support the healthy aging of the elders of my family, as well as the elders of the community. We will now open the floor for the reaction of Ms. Priscilla Cuevas. Welcome back, Ms. Presi.
Yeah. Again, good afternoon, and thank you for the second time for the opportunity again to react. Thank you, Dr. De La Vega, Shelley, for your presentation. Indeed, your study, the results of the study, has highlighted the fact that the health.
Thank you.
That
I am ready for the question and answer portion.
Yeah. I'm still reacting, Shelley.
Oh, sorry.
The results of the study has actually highlighted the fact that the health system is really inadequately prepared to address the needs of the Filipino older persons, from the primary to the higher levels of care, even in our hospital facilities, from our society, the community level, and our local communities in general. And this is much more so felt now that there is the pandemic. Parang very challenging magiging old dito sa Pilipinas. Kaya lang nandito na tayo sa ano na ito, sa age na ito na kailangan na talaga natin siyang bubunuin at bigyan ng pansin. And the results actually and the recommendations that you have provided actually has brought forth a lot of implications and a lot of ramifications on the way we work now in terms of our health and wellness program for senior citizens. The Department of Health, of course, has this program. And health needs and services are endeavored to be incorporated in the basic primary care packages offered in various primary care facilities in the country, but it seems like they are not adequate, or they are not enough. But there is a need really to step up, and there are a lot of things that has to be done, and lots of things that needs to be put in place. The recommendations that you have set forth here in this study are very varied and reaches towards a wider spectrum of influence rather than just the health sector. So kung titingnan mo, marami talagang dapat iabutin para dito, because this is really a whole of government and whole of society approach. But let me just point out one fact. For the national, kasi I'm reacting from the national mental health program from the point of view of mental health, there is a need to provide adequate and accessible mental health support and interventions who are actually needing them. the result really shows that there are people who are actually already experiencing these mental health issues, and yet they are not aware that they are actually experiencing them, and that is something that is alarming at this point in time. And we know very well that mental health activities for the elderly has been pushed, particularly capacity building for the dementia toolkit, di ba? Tuloy-tuloy pa rin yun, Shelley. And the
Yes.
MH gap that we are pursuing, and we provide to, in order that we provide needed intervention at the level of the communities on the primary health care. And we are now providing actually medications for patients who would need them, particularly for the dementia and for other things. However, I felt that, and you have mentioned this, you actually gave emphasis on the life course perspective. So if we are going to be really going to have a fit older person, we need to really start from a fit child, a fit
Yes.
infant, actually a fit fetus, a fit mother, a
Fit
mother to
mother.
be, a fit mother to be, a fit parents to be. Wala pa nga eh, kailangan fit na sila mentally, physically, so that when they bear children, they're also going to be fit, and when they become adolescents, when they become adults and older people, senior citizens, they are fit, and they are able actually to weather the storms that comes through their ways accordingly. And so I feel that all the more the mental health promotion from that point of view, again, of mental health promotion and resiliency should be given much emphasis, and should really be the backbone of all of our endeavors, starting from the early stages of life, so that when people grow old, they are more capable of withering and addressing their own various concerns. And the Department of Health Law provides the opportunity actually for strengthening and building capacities for mental health promotion and addressing all of these concerns. So all of the things that you have discussed there, and all of the recommendations that you did from the point of view of mental health is really very important. And be rest assured that your recommendation will be incorporated and used appropriately. Again, I would like to just end and tie these things up, that when we talk about this population, again, it cannot be separated from the entire that for the entire government and the whole of government and the whole of society, addressing the various social determinants that we have at a life force perspective. So it's really something that the entire government, the whole of society has to address, from poverty to the different aspects of life of people in the communities, so that when they live through their lives, different stages in life, and as they reach the their elderly years, as senior citizens and as um, uh, as older people, then they are able to live in a life in a society where quality of life is very much being given premium for each and every one. So thank you again for reminding us that we need to work, and we need to really hold hands together as a community to really push for this. Kasi hindi naman tayo pwedeng hanggang bata lang kung hindi tayo din po ay tatanda. And we want to live in a society that puts premium into ensuring that our elderly people are living in lives that are quality. Thank you.
Thank you, Ma'am Presi.
Okay. Thank you, Ma'am Presi and Dr. Shelley. I think the participants have the same feelings. Parang we share the same feelings. This study really affected me at my personal level, just like what I mentioned earlier. Your presentation, Dr. Shelley, parang it challenges me to ensure, to support the healthy aging of the elders, of the family, and the community. Um, I think for answering questions from the participants is in order. I think they're excited to hear your insights and explanations to their questions. The first question po is from Ms. Rafaelita Lucena. The question is, health for OP is a great concern, especially for the poor and the underprivileged. There's really a problem on availability and accessibility to health services. Any move or plan to improve the services?
Okay, I think DOH will probably have to answer that. DOH has a
Yes.
health and wellness program for older persons, no? And I know Ma'am Mimi Binluan is in charge of that. And of course, for mental health, we have Ma'am Presi. Both of them have really been very good partners in the DOH when it comes to planning all of these programs. We really want to have health and wellness programs for senior citizens. And that plan, I'm not from DOH, but it includes a comprehensive geriatric assessment, fitness programs, nutrition, a better vaccination program, and of course, focusing on disease prevention, and of course, the provision of acute care services. No? What we are looking forward to is also an expansion of services to include home care, because a lot of older persons are homebound. They can no longer go to hospitals, and hospitals are not always the best places for them. So we are wishing for more expanded programs with regards to caring for homebound older persons. But at the moment, the pandemic, what are we doing? We geriatricians are doing teleconferences. We are doing telehealth, teleconsultations, no? And home visits. And of course, this is very difficult. But this is also where communities, no, older persons, the BERTs, the BHERT, very important role. Our barangay health emergency response teams, our BHWs are doing a good job taking care of older persons who are affected by COVID. I think we need a direction, better direction towards telehealth and telemedicine.
Okay. I think for your answers po, can also answer the question. Someone from the someone from our viewer is asking this question. Well, what can be the possible recommendations to better support the Filipino elders in terms of service delivery?
So I think that was what I had already answered. Let's wait for the National Health and Wellness Program for senior citizens.
Okay.
And of course, there is a life course approach, by the way. We have services for the life course. As emphasized earlier, we need to look at not just older persons, but even make sure that the mothers, future mothers are healthy, and future fathers are also healthy.
Okay. Thank you, Dr. Shali. The second question po is there a data showing the socioeconomic distribution of elder population experiencing or feeling dementia-like symptoms? This is with an assumption that elder population in the rural areas have less access to mental health education and support.
We can analyze. We are further analyzing our data, of course, based on socioeconomic variables. Of course, we are also analyzing according to region, sex, and age. But if you look, there is a recent study by the Lancet Commission looking at reversible or possible conditions that lead to dementia that as a community, from a public health perspective, we can do something about. And this would include, of course, more education. We need more education because education has been linked, of course, to socio-economic capacity. But if we, before the age of 40, have more educated people beyond elementary grade, at least into high school, then we have less people who will have dementia. No, also pollution. We know that many of the areas, especially in the urban poor areas, live in highly polluted areas. That's very important. Tobacco is also linked to socioeconomic status, and we know that the poorer people are more subject to the adverse effects of tobacco smoking. So these are things that we know, but we are currently analyzing our data further.
Okay. Thank you, ma'am. Thank you for answer. There's another question po from Ms. Levita Mapatak. The question is there a data that connects more mortality for older people or frailty in facing the pandemic time? And what are the actions of the Department of Health on the services for the geriatric patients? I think this question is should be addressed to Ma'am Presi.
Well, let me just answer the data on COVID mortality and older persons. Worldwide, there really is an increasing trend of mortality among those aged 60 and older, from 3% when you are 60 years old to almost 30% when you are 80 years old and above. But like I said, in one of our policy recommendations, not every facility is reporting COVID according to age. No? We really need to disaggregate and analyze our COVID database and look at 60 to 69, 70 to 79, 80 and above, and sex, because there really is a difference all throughout the world, all over the world rather, and I'm sure in the Philippines also. But that data needs to be more apparent and shared more.
Okay. Thank you. I think that would be all for this Q&A portion. Again, thank you, Dr. Shally Ann de la Vega and Ms. Priscilla Cuevas for sharing your expertise with us this afternoon.
Thank you, everyone. Thank you, Presi.
Thank you, Shelley.
Okay, we will proceed now to the presentation of the fourth study. The title of the study is End of Life Care Preference Using a Simplified Advanced Health Directive Tool Among the Elderly Consulting at Zamboanga City Medical Center Outpatient. We will be joined by Dr. Andres Kim L. Tan III in presenting his study. Currently, Dr. Tan is a medical officer 4 at Zamboanga City Medical Center. Welcome to the forum, Dr. Tan.
Good afternoon, everyone. So, may I start? So, before I start my presentation, I have taken some quote from Shukala New. He's an award-winning novel author of Fight Club, which is starred by Brad Pitt. He quoted that we all have to die one day. Our objective is not to live forever, but to create something that will stay forever. So with these thoughts in mind, that we know that we need to do tangible things to remind the living of us. So it's not done by the word of mouth, but by writing it down for everyone to see, to read. And that is a path of every living being to go past through. It is a word that no one likes to hear in the every deathbed conversation. Some of the stigma's reasons for talking about death are attributed to lack of time and feeling of emotional strain when talking about it. The difficulty in managing conversation in practice can be challenging expressing it, especially to people who don't like to listen. And especially talking it with elderly people, it is sometimes a taboo to mention this term to them. So the medical ethics dictates the highest ethical strategies among medical practitioners. These are the medical ethics principles written on the slide. We are not going to discuss every principle. We're only going to touch the topic of the moral principles of autonomy. Autonomy conveys the right of the patients to choose any current proven safe and effective medical management that may be beneficial or not to him or herself. This is the principle based by the Advanced Healthcare Directive. Before we're going to discuss the proper topics, we are going to define some definition that we are using in this presentation. First, what is end-of-life care? End-of-life care is a medical care given to senior citizens who are most likely to die within the next 12 months. These include people whose death is imminent, expected within a few hours or days. And those with, number one, advanced progressive incurable condition. Number two, general frailty and coexisting conditions that mean they are expected to die within 12 months. Three, existing condition if they are at risk of dying from sudden acute crisis in their condition. And four, life-threatening acute condition caused by sudden catastrophic event. The next definition we are going to define is what is Advanced Healthcare Directive. They are sometimes known as Living Will, Personal Directive, Advanced Directive, Medical Directive, or Advanced Decision. It is a legal document in which a person specifies what action should be taken for their health if they are no longer able to make decisions for themselves because of illness or incapacity. Some authors say that there are four types of advanced healthcare directives. These are the living will, power of attorney, decision order of life-sustaining treatment, and do not resuscitate. We will discuss what is a living will, which is like an inheritance will. So it states what medical management or what living's relative will do to his or her body when he or she is dead. So these medical management include the CPR, the medical ventilation, tube feeding, dialysis, antibiotics or antiviral medications, comfort care or, as we say, palliative care, organ or tissue donation, and even donating your body. It also includes anything that will enrich by your relative from serious to bizarre requests. And next is the durable power of attorney for healthcare, or we say also that's medical power of attorney. It's a type of advanced directive in which you name a person to make the decision for you when you are unable to do so. So some terms they are also called as dual power of attorney for healthcare or as an healthcare proxy. So the person that is sometimes called healthcare agent, healthcare proxy, healthcare surrogate, even patient advocate. So they are the one deciding what will happen to the patients or the medical management will be. So even what all of these are legal documents. So it doesn't mean that you have decided what medical management was done to be done. You cannot change it. So until you are conscious and sane, you can change it many times. So pulse, the next type is a vision order for sustaining treatment, is an advanced healthcare planning. It's similar to advanced healthcare directives. Ang difference nila is that it's a medical order for life-sustaining treatment. So this form does not replace the other directives. Instead, it serves a doctor order instruction, not unlike a prescription, to ensure that in case of emergency, you seek the treatment you prefer. So this, the doctor will fill out the form based on the content of your advanced directives, the discussion you have with your doctor about the likely course of your illness, and your treatment preference. So the pulse stays with the patient. If you are in the hospital or nursing home, that document is posted near your bed. If you are living at home or in hospice care facility, the document is prominently displayed where the emergency personnel or other medical team member can easily find it. So the pulse includes the resuscitation, mechanical ventilation, tube feeding, use of antibiotics, request not to transfer to an emergency room, request for not to be admitted to the hospital, and pain management. And the last type, which is the DNR, or the do not resuscitate. So you don't need to have an advanced directive or living will to have this type of documents. So it is already found in the hospital. So you just tell your doctor about what is your intended DNR, and it will be written in the medical record. So mostly DNR are done during patients on arrest in a actual scenario. So supposed to be the patient will be the one deciding what's the DNR for him, but usually the proxy are the decision maker, the ones who decided. So during the final breaths of the patient, so there are many dilemmas occurring. First is there are many decision maker to decide what medical management to be done. So if there is a medical management, it's mostly closely for the caregiver, patient's caregiver. So even it is futile. So some medical equipment and supplies being wasted, and it causes medical personnel stress. So for the family member, these are the problems are they are blaming games among relatives. There are some misconceptions of dying and miracles, and some also question physician credibility in managing the diseases, the guilty feelings of decision maker, and sometimes there are too many decision makers are deciding on what's the fate. So the question is, are we as a the person who is in question ready to decide what end of care life preference? So the general objectives of the study is to determine the end of life care preference among the senior citizens of Zamboanga City Medical Population. There are three specific objectives, which is the one is to show the democratic socio-economic characteristics of the subject. Second is to determine the preference of the senior citizen due to which medical care and the place of dying. And lastly, to determine the difference in the end-of-life care preference among the different elderly age group. So the medical design is a cross-sectional, it's a survey. So this survey is based on these three good questionnaire, the form for Queensland, the post form, and the study by Davidson. So the study setting is the Zamboanga City Medical Center, Outpatient Department, Wartman Building, third floor, at the Family Medicine Consultation Clinic. So most of the respondents are elderly patients consulting at the OPD. So they are divided into three groups of age, greater than 60, so 60-69 as young old, 70-79 as middle old, and old which is greater than 80. So they have a good cognition and judgment. So the exclusion figure, dementia, delirium, depressive mood, with debilitating comorbidities that need admission are not belong to us. The sample size is about 401, and these are the demographic data that we collected. And these are the tool survey, the two questions. So the result of the study. So most of the respondents are female, and most of them belong to the young old or from the 60-69 age bracket. Majority of the respondents are married. So the religion, most of them are Roman Catholic, followed by the Islam religion, and majority had no formal education or at least at elementary level. So most of the respondents came from Zamboanga City, and majority say rented and own supplies relatives are their home ownership. The source of income are mostly dependent on their children, and the average of children for each elderly came about 46, and mostly they are living with their spouse, children, and grandchildren. So the result of the study is that majority of actually 100% of the respondents do like to continue IV fluids and the medications. CPR as 86%, and continue nutrition by tube feeding at 74.1%. The only thing that they are not undecided, which is 48%, the continue for intubation, and 51.1% doesn't like intubation. And the preferred place of dying for all our respondents are 74.8, which is the hospital. So based on the age group of their preference, there is no changes on the of the result, except for intubation, which is preferred, not preferred by the old age criteria, and so the nutrition are somewhat people undecided from the old perspective, and mostly still preferred to die in a hospital. So the conclusion of my study is that the studies still show that senior citizens in some cities still wanted Medicare despite its utility when they were dying. Their common preferred place of dying was still the hospital. Intubation still remains a medical care that should be asked and explained to the family of the patient themselves. So the inclusion of that topics in early consultation should be part of the consent process for elderly medical management. Some of the recommendations are the study can be replicated from the different regions of this country, can be used at the critical patient setting, and some of the study does not address the emotional feelings, communication, and respondents' perspective. So therefore, I suggest or follow-up study use it for the type of research. So there is a need to discuss end-of-life care and the topics at topic consultation among senior citizens. And it should be part of the educational information at all levels of school. The incorporation of that topic should be part of counseling process of any patients or topic. So advocacy of end-of-life care should be part of the public agenda. With the implementation of the advanced directives in the country must be asked to our legislative body. So there is a need for a hospital to establish hospice care or end-of-life care. And we should always personalize medical care tailored to patient preference. So in the end of my presentation, that before you're going to die, at least you have to leave a will so that those people, those decision makers, those families, so they know what you want to do. They need to know what do the patient like or the client like to do about his body. So from from dying to the cemetery. So that's the point of the end of life care. So thank you.
Dr. Tan, thank you for that presentation. Actually, this presentation would support the presentation of Dr. Shelly Ann De La Vega. Since we're aiming to have fit frails in our society, we're also empowering them how they're going to end their life as part of healthy aging. Thank you so much. Okay, we will now open the floor for the reaction of Ms. Frances Priscilla Cuevas. Welcome again, ma'am. Welcome back. Thank you.
Yeah, I was really looking forward to reacting to this study that was done by Dr. Tan. And thank you so much for doing this. This is very interesting. And an eye opener to all of us follow up, particularly us here in the Department of Health. But it will really be very interesting, as you said earlier in your recommendations, that this should be replicated. No, could be interesting to see the results how different it would be because I mean the study was done in Zamboanga, just one hospital. Medyo concentrated yung ano nila yung the kind of people who are there, probably the kind of thinking then, and the kind of reactions that they have, you know. But just looking at that is very, very interesting on how they look at end of life care preferences that they would like to have. So maybe there are people here who are listening to us. They would like to replicate this in a bigger manner across the country and in different settings with different types of people, etc. Okay. I would like to say that the Department of Health has an administrative order signed in 2015, which is the National Policy on Palliative and Hospice Care in the Philippines. And I'd like to read the rationale why we have this policy. And it says there, with an aging world population and the escalating incidence of communicable and non-communicable diseases, the demand for end of life and palliative care is increasing, you know, every year. And there are people who would actually need this. 20 million people are in need of such care. 6% of which would even comprise children, not only the elderly. On top of this, around, just in sabi, 20 million more required palliative care before death. Despite the figures, only a few countries have implemented equitable palliative care programs through a public health approach. And we're happy that in the Philippines, we are actually at this point in time doing a manual of operations and procedures that will operationalize this national policy on palliative and hospice care. This is something that we really would like to be able to do because it guarantees our constitution guarantees the right for people to quality health and the need to integrate palliative and hospice care into our healthcare delivery system, no, ranging from the promotive, preventive, curative to rehabilitative, and then we should be able to put in basic palliative and hospice care in all of our facilities all over the country. And I think this is also one of your recommendations that we need to be able to have some kind of hospice care in the Philippines. And I agree with the recommendations that there is a need to discuss end life of care and death topics, no, in various settings, that probably just in outpatient departments. This should be something that should be included as part of the curriculum maybe. When you know, sometimes when we talk about death, mga estudyante, kahit mga doctors, mga nurses, sometimes they feel inadequate. No? There's some sense of inadequacy in dealing with topics of death. And but I think these are some of the things that we cannot avoid, and we should be, you know, as health professionals. I think we should be able to incorporate death topics as part of the counseling process in our engagement with our patients. And yes, hindi lang po siya nasa hospital, sa facilities, but really it should be a public health agenda that should be followed through. That's the reason why this manual of operations that we are working on, we hope to be able to finish it. And this is being done by JBL, the JB Lingad Hospital for the Department of Health. And we are working on the standards, the guidelines, and yes, we will, as part of the reaction today, we will tell them that there is such a thing as this, and they can take a look at the result of this study, and we can put in some substance, no, into the recommendations that you have and incorporate it in the guideline, in the manual of operations that we are now working on. Another area that I'd like to point out is that even in the implementation of the Mental Health Act, there is a portion there on informed consent and advance directives. Kasi pag ganyan, if you are if you have mental health issues, if you are already in a state where you can no longer make a decision, sometimes you need to have some advance directives or advance directives or even a supported decision making. So we're doing a guideline for informed consent to treatment, exceptions to informed consent, advance directive, legal representations, and supported decision making, at least for those who are with mental health issues or mental health problems. But I'm thinking, um, if we are going to take a look at this, we're going to review our guideline again and to find out if there is a need, to kasi kailangan pa ng legislation ito, no?
Yes,
As you said kanina, kailangan ng legislation. I don't know where we can, but let me get back and we can go back to this and find out whether the advanced directive portion here is something that we can take a look at. Yeah, there are, what I'm trying to say is there are areas at this point in time, there are policies that we are working on, there are issuances that we are working on, that this particular intention maybe we could put into place. We are also doing a lot of capacity building materials and modules, and we will be looking at with the back of our mind counseling, death on death topics and all of those things, building capacities for our health workers to be able to counsel people on death topics. And thank you so much. And I think this is very, very
Thank you,
interesting.
ma'am.
Very helpful to us. And hopefully some people can pick up, the study that you have and replicate it and make it a bigger one so
Yes,
that
ma'am.
we will be informed some more. Okay, thank you so much.
Thank you, ma'am, for that nice comment.
Thank you for raising those points, Mom Pressy. We will now open the floor for the Q&A portion. Just like me, our participants are interested, are excited to hear your answers to their questions. The first question is, Dr. Tan, with end-of-life care, should we include as well burial arrangements, as this is connected in the disposition of the cadaver from the morgue, or should we include questions on burial arrangements to ensure that the loved one is taken care of from the time of death until the burial? Your comments, po. Thank you.
Actually, it depends on the patients or the one who is dying to choose what type of burial setting he wants. So that's part of the living will. So one of my patients, when we are talking about, sabi niya, she likes Hello Kitty coffin. Yeah. So we told
That's
that
nice.
we to her mother. So I don't know if they did it, so because it is out of our reach already.
Doc, there's another question po. From Mr. Leonardo Alcantara. The question is, does Zamboanga Medical Center include the subject of death when managing old patients? How do you introduce this subject during OPD consultation?
Actually, we are not yet implementing the that topic because it's still new. So we just have our new consultant for the palliative. So maybe next year we'll be starting the inclusion of that topic. So usually we are doing it most on cancer patient only. At OPD setting, it's not yet implemented. Hello.
Thank you, Doc. There's another question po from Ms. Nina Sandit de Rosas. Family members should also be included in the preparation for end-of-life care, especially since there are still patients who prefer to be cared for by their family members, whether at home or in an institutional setting. However, is there a program that can be used to address the psychosocial issues that they may be experiencing as they care for family members at the end of life?
Actually, it is part of the palliative uh, and hospice
Yeah,
care, anong tawag
yeah.
natin, objectives to take care of the family of the dying at the end of life. After burial, we need to have a counseling before the parang dapat kasi may time, and problem kasi we have only one consultant. It will be difficult to address all our dilemma, yung mga. So some family can ask us to do the tawag nito, grieving counseling.
Okay, thank you for that, Doc. I think there's another interesting. Yes. There's another interesting question po. With the Filipinos' inherent superstitious culture, how do we improve the acceptability of the Filipinos regarding end-of-life care in the country?
As my recommendation, no, we have to put it into the 3 levels of education. Educating the new generation on the death topic is better than changing the beliefs of those who are already superstitious about it. It's difficult.
Okay, thank you.
Agree. I agree.
Okay, rooting on death as a taboo issue in some culture, Mr. Joel Jimenez po actually parang just want to ask for further clarifications. Are there factors that might change the perception of OP in pre-deciding their death covered in the study?
Yes. It depends kasi on the patient, on the person values, spiritual belief, education background. So sometimes it can be swayed by family members. So the advanced healthcare directive is not parang permanent siya. You can change it from time to time. If you change your mind next week, you can again ask your lawyer to make another statement.
Okay. One last question, Doc. This is from Mr. JP Dalupang. Dr. Tan, would you have insights on why a lot of the respondents prefer to die in the hospital? Does this have something to do with the process of dealing with deaths at home?
Na,
Which is Gracia.
The research did not it's not the limitation of the research. Pero for my own theory, it's actually some people still like professional care. Sila yung one, they need some medical healthcare professional to do the medical management. So we, as a Filipino, no, we believe na may miracles. So we hope na yung life can be saved despite its futility. So I think a study must be needed to address this topic.
Okay. Thank you. Thank you for your enthusiasm to answer all the interesting questions from our participants.
Okay. Welcome. Thank you for inviting me.
Thank you. Yes. Well, thank you for saying yes to our invitation.
Thank you.
Yes. Thank you, Dr. Tan and Ma'am Presi, for sharing your expertise with us this afternoon.
Thank you.
I think that's the end of the Q&A portion of the fourth study. Okay, we will proceed now to the synthesis of what have transpired in the 2 days. Session 1 and session 3 rather, part 1 and part 2. In the part 1, Um, we have discussed the importance of health workforce and health facilities and ensuring that there's an excellent health service delivery. According to Dr. Gregorio Medel, plans would only happen if there are warm bodies. Plans, policies, systems, financing, this could only work if we have competent and compassionate health workforce. So we should be bold in making visions. Planning makes us hopeful. That's the message that they want to send during the part one. Just like what Dr. Rojas said, we should not jump off the ship. We should, even in this time of COVID-19, we should not be dissuaded in ensuring that there will be excellent health service delivery. In session 2, we zoom into special populations, trying to understand the current situations the special populations are facing during this time of COVID-19. Very interesting studies focusing to our elderly, focusing to our um, vulnerable children, as well as our working OFWs and migrants living outside the Philippines. I would like to make this bold statement that the session have been so productive. There were fruitful exchanges of ideas. Again, um, we could ensure health service delivery even in the times of COVID-19 if there are functional facilities, and if we would be able to institutionalize competent and compassionate health workforce. Thank you for joining us today and yesterday. Thank you, everyone. We will have just few reminders. If you've encountered problems during the webinar, lost connection, or did not finish the webinar, links to the webinar replay will be sent to your registered email address. To receive a certificate of completion for this webinar, please take the quiz and answer the evaluation via the link, which will be sent to your registered email address a day after the session. Participants are only allowed to take the quiz once. You need to score 80% or higher to receive a certificate of completion. Otherwise, you will receive a certificate of attendance. If you only wish to receive a certificate of attendance, just go to the link that will be provided to you via email. The webinar quiz will only be available for the next 48 hours after the links have been sent. 48 hours after the links have been sent, please take note. After the quiz is closed, your certificates will be issued at a later date after verification of scores. As a final reminder, please double check your email address during the registration. Incorrect email addresses will not receive related announcements.
Thank you very much, Ms. Daabay. Thank you for facilitating our part 2 for today's session.
Okay.
Just some reminders, no, ma'am. We have 2 more upcoming NHRFA 18 sessions. One on November 12 from 9 a.m. to 12 noon, focusing on optimizing financial resources for UHC in times of pandemic. And on November 13, again from 9 a.m. to 12 noon, COVID-19 lessons and ways forward. Okay. Just a reminder on how to register for the NHRFA sessions. After filling in the registration via the registration link, please make sure to register to Webinar Jam to gain access to the webinar link. To do this, click the link provided for each session to register to Webinar Jam. Once in Webinar Jam, please click the register button seen at the bottom right corner of the page. Fill out the form and click the Register Now button. Please make sure and double check that your email address is correct. Wrong email addresses will not receive the link to the webinar session. Then you will be provided a link to the webinar. Please take note of this. You will go to this link on the day of the webinar. In addition, after a few minutes, you will receive an email containing the webinar link and registration confirmation. You will also receive an email 15 minutes before the webinar to remind you that we are about to start. For questions and comments about the webinars or to reach the organizers, please send an email to NHRFA, NHRFA 2020 at gmail.com. For questions or inquiries about registration and certificates, please email us at nhrfa.ituro@gmail.com. Again, in behalf of the organizing team from DOH, DOST PCHRD, and ADMO IPC, we thank everyone for joining today's session. Thank you very much and have a good afternoon, everyone. As mentioned earlier, you will be receiving a link to the replay and to the evaluation and the post test via the email address you used to register for Webinar Jam. Thank you very much and have a good afternoon.